Good afternoon, everyone. It's my real pleasure to welcome you here to the second session of Virtually Casper. My name is Maggie Caristecci. I'm part of the team at Casper here, and we're thrilled to welcome you to this session, Power and Peril, How Information and Informatics Are Shaping the Pandemic Response. I want to begin by doing a land acknowledgement. I want to begin by acknowledging that we're on Indigenous lands. We recognize that an acknowledgement of the land is only a beginning. Today, we pay our respects and want to express our gratitude to the First Nations and Métis people who are the traditional guardians of this land. Today, we reaffirm our relationship with one another. We need to respect the treaties that were made on these territories, acknowledge the harms and mistakes of the past, recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, and government systems. And we dedicate ourselves to moving forward in partnership in the spirit of reconciliation and collaboration. I want to begin today just with a few housekeeping rules, lest you think that because it's a virtual conference, there are no housekeeping rules. There are, in fact, and we have a few. Washrooms are down the hall, likely across from your bedroom. Snacks, well, snacks will have to come from your own fridge, so enjoy those. Seriously, though, we do have a few logistics we want to go over with you. You should feel free to write your questions using the Q&A function at the bottom of your screen. You can do that anytime during the session. We'll do our best to ask as many of the questions as possible during the Q&A session. Because there are so many participants and we're a small but mighty team of just a few people, we ask that all questions be posed using only this feature so we can keep track of them. We invite you to pose your questions in both English and French. The chat feature will be disabled until Dr. Zelmer is finished her presentation and when the Q&A is made live. Of course, we're certain that all participants will observe respectful communications in both the Q&A and the chat features during the session. So I'd like to extend our sincere appreciation as well to the sponsor of this session, the Canadian Patient Safety Institute. It's our great pleasure to include the McNaught-Tyon Award as part of Virtually Casper. I'd like to first introduce you to Diane Parker-Tyon, who's going to give you a little bit of a background about the award and introduce you to how this all began. Diane, it's a pleasure to welcome you today.
Thanks very much, Maggie, and thank you for the opportunity to be here. And thank you to all the participants for being part of our presentation today of this award. The McNaught-Tyon Award, or M&T Leadership Award, as we like to call it, was established in 2008 to honor the outstanding and lasting contributions of the late Don McNaught and my husband, Serge Tyon. Don and Serge were two individuals who personified leadership and mentorship, and who promoted the development and use of high-quality health information at all levels of decision-making in advancing evidence-informed health policy across Canada. In fact, they were pioneers in this area. As senior public servants serving in a number of senior leadership capacities at Health Canada and elsewhere, Don and Serge worked side by side to contribute their leadership in a spirit of cooperation to initiatives such as the Canada Health Act, the National Health Information Council, and the National Health Information Task Force. Don was referred to as Mr. Medicare, and Serge was instrumental in the formation of CIHI. Their vision, values, and perseverance contributed significantly to the realization of a better health information system and healthcare for all Canadians. Don and Serge's legacy is honored through a partnership of three organizations: the Justice Emmett Hall Memorial Foundation, the Canadian Health Leadership Network, CHLNet, and the Canadian Association of Health Services and Policy Research, CASPER, our host today. The M&T Award has been made possible by generous private donations with matched corporate donations and individual charitable contributions. The funding is held in trust by the Justice Emmett Hall Memorial Foundation and donations are still gladly accepted. I would like to at this time acknowledge Bill Thal for his instrumental role in the creation of this award. Bill and a few dear colleagues met several times with Serge to discuss the focus and terms of the M&T Award before Serge passed away. The M&T Award is a nominated award that recognizes outstanding individual contributions to Canadian healthcare through emerging and exemplary leadership and mentorship in the advancement of the values of the Justice Emmett Hall and evidence-informed policies and programs across Canada. A national committee with representatives from the 3 sponsoring organizations and the McNaught-Tyon families selects the award recipient. The award is presented every 3 years at the Casper annual meeting. Since the inception of the award, we have celebrated the contributions of 4 esteemed leaders, including Dennis Prati in 2008, Dick Alvarez in 2011, Les Roos in 2014, and Brian Postal in 2017. The award is accompanied by a $1,000 bursary given to an emerging leader as selected by the M&T Award winner. Now, drum roll please. On behalf of the 3 partner organizations, it is my very great pleasure to announce that this year's award goes to Dr. Jennifer Zellmer, President and CEO of the Canadian Foundation for Healthcare Improvement. The presentation this year has special significance as Jennifer was one of Serge's colleagues in the early days of CIHI. In addition, Jennifer has asked that this year's award be given to a patient partner leader to be adjudicated by other patient leaders. I believe that Serge would have been very pleased with this recognition of the importance of patient partners. During his 4.5-year cancer journey, Serge wrote an inspirational blog charting his own personal experiences as a patient in the healthcare system, including the ups and the downs. He ended every posting by reminding us, remember, it's a good day to be alive, something that still rings true, perhaps even more so today. I will now turn it over to Maggie to introduce Jennifer and speak a little bit more about the selection of the emerging leader for the bursary this year. Thanks very much.
Thank you. Thank you so very much, Diane. I'm absolutely delighted to introduce our speaker today. While many of you know her as Dr. Zellmer, the healthcare leader, I have the privilege of knowing her not only as the brilliant Dr. Zellmer, but as a colleague and as a friend. I won't tell you over how many years we've connected and reconnected in various capacities throughout our careers. I first met Jennifer when we both worked at CIHI, and I also had the honor to work with Serge Tyon at that same time. So this is especially meaningful for me. They were the dream team. They were the people that we looked up to. Jennifer, not only has your expertise influenced my career, but I've found inspiration in the passion that you've consistently shown for the importance of shaping healthcare with patients and caregivers in a way that benefits them and their families. That's why this year we're really pleased to tell you about an innovative shift in the selection of the emerging leader for the bursary associated with the M&T Award. This year, in recognition of Jennifer's commitment to the patient and caregiver experience, she has elected to award this bursary to an emerging patient leader. You'll see on the slide here the link to the page for more information about the application process for patient leaders. It's on the CFHI challenges page, and we'll also make sure that we post the link in the chat box when we're having our Q&A. I just want to end before I introduce Jennifer by just telling you a little bit about what she's taught me when it comes to data and evidence. Data taught me, or Jennifer taught me, that the path to all good policy and healthcare program travels through data and evidence. And she taught me that we could always strive for better, that we should always strive for better and seek new ways of improving healthcare. And so it's my really great honor and especially delightful for me to introduce you to the McNaught-Tyon Award recipient this year, Dr. Jennifer Zellmer. Jennifer.
Thank you so much, Maggie, for those kind words, and also for the fact that you didn't fess up to exactly how many years we've known each other. So that's all good as well. And huge thank you to everybody who's made today possible, whether it was those involved in the award or all of the people who've been working so incredibly hard to put together this amazing Virtually Casper program. Thank you. And thank you to everyone also for joining us today. I know we've got people from coast to coast to coast across the country. And so it seems appropriate in that context for me to begin by acknowledging that I am coming to you today from Ottawa, the traditional unceded territory of the Algonquin and Anishinaabeg peoples, and to acknowledge, given our coverage across the country virtually, the rich traditions of learning, of information sharing, of health, and of healing that are core to so many of the First Nations, Inuit, and Métis peoples, and have been for such a long period of time. And that core was also something, as Diane said, that Serge and Dawn shared as commitments themselves. I had the privilege of working with both of them, Serge for many years at Ki-Hi, and Dawn only briefly when I was a wet behind the ears baby bureaucrat at Alberta Health, working with the National Health Information Council. But their commitment to public service, their true dedication to the health of the public shone through in everything they did. And if they were here today, they would definitely be in the category of those who aren't bored, running towards how they could help and how they could make change. And a big part of, I think, how they would do that would be with information and informatics, because they both truly believed that the road to health passes through information, and that informatics and information are the lifeblood of a well-functioning health system. And so that brings us to the topic of today's conversation. And I hope it will be a conversation, and encourage you to do, as some people have started to do, add things to the Q&A as we go. You don't have to wait until the end for a big rush. Because I think in our current times, personal protective equipment, it's the visible symbol of pandemic response. We see the masks, we see, the gloves, we see all of the posters around how to wear them appropriately. It's behind the scenes, but I think it's true that information and informatics are just as important for effective action by public health, by healthcare providers, by government, and by each of us, by society as a whole. But in that context, that power is not without its perils. And it's both of those dimensions that we want to explore in the course of today as we think ahead to what's really needed for this transition phase that we're entering into now. So if we can move to the next slide, this insight in terms of the power of information in health and healthcare is not new. And last month was Nurses Month, so it seemed appropriate to bring Florence Nightingale to the floor. As many of you probably know, she was a master statistician. She had a major focus in her career on outbreak management, both on the front lines and in policy. She was the one, for instance, who was really forceful about the fact that more soldiers died from disease than died on the battlefield. And she said, and I quote, "Statistics is the most important science in the whole world, for upon it depends a practical application of every other science and of every art. The one science essential to all political and social administration, all education, all organization based on experience, for only it gives the results of our experience." And you hear similar echoes of the importance of information and of shared information, reading back through ancient Greek, ancient Indian, ancient Chinese medical writings. So that's been known for a very long time. But it's also true that it's not a new insight that there can be perils as well. So he wasn't the first one to say it, but popularized by Mark Twain was that lies, damn lies, and statistics adage. And so we see that balance and dynamic playing out. And if we move to the next slide, I think it's important that we think about how this plays out today in the context of outbreak response. So what you see on the slide are 5 dimensions of modern emergency response, drawing on work from Paul Farmer with a few sort of additions of my own, that look at what do we need to surge our capacity in the times of emergencies, and what do we need to sustain that surge. And I want to explore information and informatics in each of these. And we'll start with society, the first one on the next slide. And if we think about society, I think we would all agree that information is absolutely essential to public health response at the societal level. You know, reflecting back yesterday, if you were at the student working group session or this morning, many people talked about the importance of communication in this current context, the power of that communication and the ways that we need to understand how to do that well, and where sometimes it may be even better if we did it another way. And so, you know, we've heard call outs to some of the amazing communicators like Bonnie Henry in BC and others across the country who've really come to the fore in this pandemic. And it's partly because of their work that if we move to the next slide, we see that there's a broad societal awareness of some of the things that we need to do. So in an Ipsos poll recently, 95% of Canadians, for instance, say that social distancing will slow the spread of the pandemic. Although it's also true to say that the same poll found that 1 in 4 admitted to not following the guidelines as much as they should. But it's that kind of information that's essential for us as public health practitioners, as broader health practitioners, to be able to look at where a message is getting through, where are they not, and how do we fill information gaps. It's also true that informatics have been critical to many other things during the pandemic. So our ability to have meetings like this, for instance, the ability for many of us with the privilege of working at home to be able to do so. The ability also to maintain our social connections as much as possible in this time of physical distancing. But it's also important to acknowledge that this isn't just a one-way street. So WHO calls it the infodemic, the challenges of fake news and of other problems that arise, and they are prevalent. You know, in spite of the fact that a recent Carleton study found that 57% of us think that we can consistently distinguish between fake news and conspiracy theories and fact in the context of COVID-19. But that included about half of those who'd bought into conspiracy theories around the relationship with the 5G network or the relationship around the source of the virus. So we need to think carefully and to understand, and given that this is a research audience, to use the powers of our research tools, how do we lean towards the former and really amplify and disseminate those messages? So if we move on to the next slide, and the second dimension, and the second dimension, we're moving now from the very big picture to the very little, in some cases, the stuff, a less formal way of saying supply chain. And there's no question that information has been absolutely essential to where supply chain successes have occurred and also where there have been failures. We need the right tools to be able to get the things that are needed for pandemic response to those who need them, and not depend on good luck, but rather be able to use good management. If we move to the next slide, we've seen really interesting examples of standing up really fast local information sources. So I couldn't resist including this example from CHIO. They had a little fun for May the 4th, bringing some special characters into their dashboard. But being able to stand up this kind of information around local PPE supplies and the effect of various types of consumption protocols on those. So those on the front lines know where they stand and know how their actions are influencing what the results are. But we do have challenges in terms of how do we integrate this information across. So it's one thing to have it locally, but as we think ahead to hopefully an effective vaccine, you know, how are we going to manage the supply chain for that vaccine? How are we going to make sure that we've got the tools and the information to be able to do that well? And if we move on to the next slide, it's also about making sure that we're asking the right questions. So if you're not already following Our World in Data, you absolutely should. Super impressive how quickly they've stood up global, near real-time information right across the board in terms of things like mortality, hospitalizations, numbers of cases and testing in cases like this. And it's obviously hugely important to understand testing. You know, test has become a mantra of many of the aspects of public health response. It is also important that we understand not just has someone been tested, but are the results available? Do they know the results? Do they have the mechanisms to be able to act on those results? And do we have clustered contact tracing to be able to look at the next steps? And as we think about things like contact tracing, also important to think about the implications of how do we do that in a way that is privacy sensitive, that takes into account as well, not just those who are easy to count, but all of those who count as we go forward. So are we asking the right questions? Are we looking at the right sets of information? And some similar types of questions as we move to the next category, the next slide, and that's the systems that are involved. And we're definitely in the world here of complex and adaptive systems, where the resiliency of health systems comes to the fore. And in many cases, information can be the grease of those wheels, allowing us to move forward in a sensible way, even without all of the formal structures that might, in other circumstances, help that to progress. And I'd like to take a minute, given who we are around this table virtually today, to drill in on the research system. So if we can move to the next slide. How impressive is it that we've collectively around the world been able to assemble the information and the research to know so much about the virus already, given that it's really only a few months old, to already have promising vaccine trials in the field. But how hazardous is it to have some bad research out there as well, such that groups like those who manage preprint servers are having to deal with how do we exclude fraudulent studies? How do we exclude studies that might have been caught normally through other quality assurance mechanisms, but that we need to find new ways of doing that in the current context? So that's the bad side of this challenge. But if we move to the next slide, this is the problem we all want to have, but it's still a problem. So already there have been more than 11,000 studies related to COVID-19 posted to PubMed. 11,000 just since January, which is a truly phenomenal testimony of the fact that the global research community has pulled together to understand this virus from so many different dimensions. And this number doesn't even include the things on the preprint servers. It doesn't include the things that are sitting on our various laptops that haven't yet been submitted for publication. It doesn't include the research that will come out of the things that are just being funded now through the recent CIHR competitions. So the wonderful and the challenging problem that we have is how do we navigate this universe of information? How do we think about the ways that we can help people to find the information they need in this plethora of studies that will allow them to act as quickly as we all need to do? We move on to the next slide. There's other sets of opportunities and challenges around people. People are absolutely the core of pandemic response. And we should all, I think, take a minute here to acknowledge the tremendous contributions of all of those who've stepped forward, not away. And that includes absolutely those on the front lines in the health system, but also those who've stepped forward, not away, to keep society running, to make sure that we all have what we need to have to communicate, to eat, to live and have lights on, all of those other pieces that are so essential to our pandemic response. If we focus in on the folks in the health system, though, when we move to the next slide, and I love this quote from Nancy Rogers, the mother of Fred Rogers, famous for Mr. Rogers' Neighborhood, that in time of crisis, you need to look for the helpers, and our data systems do too. We need data systems that help us to understand where are the possibilities for surging capacity, for increasing numbers of healthcare providers, the volume, the skill sets, the availability, how do we increase that curve? But also, where are we at risk of reductions in capacity? Whether that's because of illness, whether that's because of fatigue, whether that's because of changes in regulations or requirements, or whether that's on a more positive note because of vacations. What's that balance of staffing? We need to understand that dynamically, not 2 years ago, but now, today, and tomorrow, so that we can effectively surge response. And if we move on to the next slide, in this context, we need to be honest about the fact that we are building on some important gaps in our knowledge base around people who work in healthcare. We know little about, for instance, personal support workers. So critical in pandemic response. We know little about the vast contributions to care that are made by families and other partners in care. We also know little about some things that have become super important in terms of pandemic response. Things like the diverse language and cultural capabilities of different care providers. So that, for instance, I've been talking recently to folks involved in the Alberta meat plant response, hugely important for them to be able to surge capacity from folks who spoke the language of those who they were working with. And it reminded me so much, Diane, of what Selge used to say, that when I'm sick, I'm not bilingual. And how can we make sure that the people who are surging into the response, those helpers, can meet that need? So last but not least, moving on to structure. And we tend to think about structure, as this slide suggests, in terms of bricks and mortar. But I'd like to broaden our conversation today to the virtual infrastructure that we need right now. So if we move on to the next slide, and you know, this is from the business world, but I think it's just as applicable right now in the current healthcare context. You know, just scratch out who led the digital transformation of your company, who's leading the digital transformation of the health sector. Is it governments? Is it clinicians? Is it healthcare providers? Is it, let's be honest, right now, the necessity of responding in the context of the pandemic? So if we move on to the next slide, you know, very fortunately, Infoway has done some polling in 2019 and more recently around how this world is changing. So in 2019, about 80 to 90% of healthcare visits were in person. And I believe that Sally, with her magic, is about to bring up a poll. So this is your test to see if you're awake, if you're still listening, and also to allow you to place your bets. And where do you think we were in mid-April? So right in the heart of pandemic response. Were we at 20%, 40%, 60%, 80%? Fill in the poll and let us know what you think, and we'll see where we end up as a group. But before I give you the answer, I'll let you give some time to fill in the poll. And I think I actually need to fill in the poll as well so that I can keep this moving on my screen. There we go, lessons learned. Let's just take a minute to talk about the virtual care in the pandemic, because I think the kinds of things that is on the screen, it's the iconic example of virtual care, right? The video visit or the telephone visit between an individual and their care provider. But let's think also about the other ways that digital health can be so important in reducing the cost of physical contact that was discussed so much on the panel this morning. So think about things like, how can we use digital tools to help people manage their own chronic conditions well at home? How can we use digital tools to help avoid medical travel? So you may still need a specialist consult, you may still need an in-person consult, but can you go in a remote community to your local primary care provider where they're connected virtually with specialists to get advice, so you don't have to get on a plane, in a train, in an automobile to be able to take that trip for care? On a very pragmatic level, the text message that comes and tells you that the waiting room's free now, you can come on up, it's time for your appointment. Or the digital tool that allows you to access your COVID test result and know as soon as possible what that is, so that you can take good actions for yourself, for your family, and those you care. Also, the things that allow us to actually improve access to care. So Sally, how are we doing on that poll? Are we ready to go live with the results? There we go. Okay, so a lot of people betting on 20% and then kind of split after that between 40 and 80. So if we can go on to the next slide, the reality is, drum roll, about 40% of healthcare visits were in person. And you can see there's not a huge difference actually between healthcare visits for COVID or non-COVID reasons. So we have shifted a huge amount in the course of really just a few weeks. And in that context, I think important to think about the fact that there's a power in this. There are also risks. And one of those risks is cybersecurity. And truly, unfortunately, there has been an increase in cyber threats to the health sector during the pandemic. In fact, the Cyber Incident Response Center has actually taken down more than 1,500 fraudulent websites or email addresses related to COVID-19 targeted at Canadians alone. So these are important issues that we need to think about as we scale and spread, as are the issues in terms of we've moved really fast, as this slide suggests, into this world. Having done that, how do we make sure now that we optimize use? So that we think about fit with workflow, we think about the engagement of patients and providers, we think about some of the other things that will mean that this is a value for the now normal that we're heading to, not just for the immediate period. And so if we move to the next slide, here's my transition to, so where to from here as we move into this new phase. And a lot of people, I think, are asking this question, the question from the little kid in the backseat of the car, are we there yet? When will we be there? But if we move to the next slide, you know, given what we know, isn't the question really, how will we carry on? Because we're at a pivotal moment in this process. We have choices about the paths that we take, and we need to be conscious that even not making a choice is an implicit choice. And so don't we want not just to restore what we had before, but actually think about where do we want to be and how can we get there? And so in that context, if we move to the next slide, I've been trying to listen to some voices from the future, to countries that are ahead of us on the pandemic curve, who may have lessons to teach us from their experiences. And this comes from WHO Europe. And they looked at 4 cross-cutting elements that they felt were essential in the transition process. And you can see how strongly themes about information and informatics, in their view, underpin that transition, whether it's around governance or data analytics or digital tech or truly responsive communications. The things that will allow us to do the things they said were so essential, to be driven by public health and epidemiology, to have the capacity for dual track health systems that effectively support both COVID and non-COVID care, that really leverage social and behavioral perspectives and research for effective engagement, and that take into account the social and economic supports we need to mitigate the effects of the pandemic, as André Peril said so eloquently this morning. And so in that context, if we move on to the next slide, what does that mean for each of us? So what, so now what? And I've been thinking about this in a couple ways. So on the left-hand side is kind of the information equivalent of wash your hands lots. It's, you know, we need to take care of cyber safety. We need to balance the risks and think about privacy by design. We need to be aware of the risks of the infodemic, to trust but verify, and to really, you know, we used to joke about it, Saj and I, as we were putting together media releases around CAHI data. We always used to say, if it looks interesting, it's probably wrong. And so, you know, when we see something that's super interesting, not immediately to retweet it to 20 million people, but to check before we do, to take that moment to pause. And also to take that moment as we think about the more positive side. How do we get to information for better health and healthcare? How do we remember the goal and look for fit for purpose information, information that is good enough to allow us to act, and that reduces the burden on those involved, that uses the power of collaboration to really leverage the collective resources that we have. And how might we think about that? If we move to the next slide, this is actually work from Ross Baker and Jean-Louis Denis from a few years ago now, where they looked at high-performing health systems around the world and what were the critical levers for health system improvement. And I think this has stood up really well in the context of the pandemic. So if we start with the gray arrow on the left around promoting evidence-informed decision-making, what we've been talking about throughout the course of this whole session, you know, it's also about how do we engage frontline managers and providers in creating a culture that really values and uses information to improve. How do we focus on population needs, not just those that are easy in our data systems, but those where there may be silences in our data systems, where we may have to work harder to both get the information we need and to share that information? How do we do that in a way that makes the right thing to do the easy thing to do, by creating supportive policies and incentives, by building capacity both within and across organizations, and by last but probably first, and this is why it was so important to me to have the bursary this year focus on emerging patient partners, to truly engage patients and citizens, and the value of being able to do that to inform our response going forward. And so just to sum up overall, if I leave you with one thought, it's on the next slide. This is the question I ask myself each and every morning. How can I add value and not noise? Thank you so much for this huge privilege. And Maggie, I'll turn it back to you.
Thank you so very much, Jennifer. That was great. It was really interesting things to talk about now. We've got some questions coming through, and clearly you've challenged people and they've been thinking about your insights and have some questions. So let's just start with those.
Let's jump.
One of the questions is, how do you think COVID-19 has changed what we consider valuable and how discordant what we value is with how we compensate the valuable?
I mean, hasn't this time made each of us just on a personal level step back and consider what's valuable and rethink, what is important to us and what are the different ways of having what's important to us shine through during the pandemic and beyond, and rethinking maybe where we put some of our focus. And I think we're seeing that in the health sector too. Some areas in the health sector where they were known vulnerabilities, and boy, have they come to the fore. And so how do we make sure that we value what we've learned, that we value the sacrifices of those who've been affected, and that we respond?
That's great, thank you. There are several questions that people are asking about the pandemic and the engagement of patients or caregivers during the pandemic. There's a sense that because things were done with expedience, patient advisors and partners have been shut out to some degree in many organizations. So the question to you from some of our attendees here is, how can we be sure that they can be on board to help? And how do we convince hospitals, other system partners, that patients and caregivers are also a source of information that can help?
I think there's a couple of things on this, Maggie. I mean, I think a number of decisions were made quickly. And so it's understandable in the context of quick decisions that we get some things right and we don't get all of them right. And so I think we actually have, and we've actually been hosting some webinars with people who've taken different perspectives on this front. There's some really great examples to learn from about where patient partnership actually has been embedded, or if it wasn't right from the beginning, is now being embedded. So how can we lift up those examples and say, you know what, for example, many of the children's hospitals have done some really interesting things. How can we learn from those examples and spread and scale them as well? There's been some really interesting engagement in policy processes too. So how do we learn from that? What are the opportunities? And I think, in many cases, it's in different ways than maybe it used to be. We may be used to having big in-person meetings, those kind of things. Obviously, that's not going to happen now. But what are the new ways that we can really embed a strong patient and public voice in the work that we do and in care as well, because it's both.
So Jennifer, you talked about how things have changed and how they've changed rapidly. So we have a question here about how do we prevent the return to some of those old ways as the urgency starts to wear off?
I mean, super important question, right? And I think partly that's on all of us. So in the health services and policy research community, it's partly on us to be able to demonstrate the value of what has been valuable in the change so that we can support it going forward. But also to be able to say, okay, so there's value here, but if we did X, Y, or Z, we're seeing this amazing example over there. How could we go even? How can we leverage that? And also to support those who are going to have to make really hard decisions in the context of a broader policy framework looking forward. And it goes back to that supportive policies and practices. How do we make the right thing to do the easy thing to do? Never more important than to ask that question now as we move forward.
That's great. Matthew asked a question that's really interesting, Jennifer, about whether you think the pandemic can reshape relationships between the health system and private companies that are key players in our health information infrastructure, so EMR systems as an example. And how do you see these public-private relationships changing? And will competition between companies continue to contribute to a fractured system? It's a lot packed into that one question. But
we could probably talk about that for the whole of Virtually Casper, actually, because isn't it interesting what's happened so far? We have seen some really creative responses in some cases, and in fact, partnerships between companies who would normally be fierce competitors. So we have seen examples like that. We have seen also companies stepping up to say, you know what, normally we would charge from this. We're making this available in the public good right now because it is so important for everybody to have access. At the same time, we've also seen some examples of, with the best intentions in the world, I'm sure, standing up tools that were not fit for purpose. And so that is a challenge for us to navigate as we go forward. And, just as we're having to think about, on virtual care more broadly, what does the now normal look like? That includes who are the partners in the now normal? And what are the roles of the partners in that now normal? And what are the expectations across that? Because it's not going to be as simple as one size fits all. It never is. And so we're going to have to think about what are those approaches that will allow us to move forward. And also, what have we learned from the successes? Because there have been many in the course of this first few early weeks of the pandemic.
Thank you very much, Jennifer. There's another question from Devin. First of all, thanking you for your presentation. So I'm gonna pass on that thanks. But wanting to know if you have any thoughts or insights on how we might address populations where good data and evidence are not yet readily available. So the examples given are LGBT communities, populations, indigenous populations, racialized populations, but the limited evidence that is available shows that there are disparities. So what are your thoughts around those?
Yeah. I think one of the things that the pandemic has done, and I touched on this a little bit in the staff section, is it's highlighted some of our data gaps. Some areas where we just haven't historically invested in the data to be able to answer some of those questions. And I think there's an impetus right now to answer at least some of them. I'm not sure there's an impetus to answer all of them. There's an impetus to answer at least some of them. And so if we think about populations who, historically, we really haven't, they've been silences in the data. They've been gaps in the data. We're shining a bit of a spotlight right now. Now, a lot of that spotlight is being shone through special purpose, short-term, sometimes local data collection, sometimes research-based, sometimes just this public health unit desperately needs to know question X, and so they're going out and getting it. Or this journalist is, committing to find out about Y and is going out and getting that information. So I think as we transition to the next stage, one of those key questions is what parts of our regular ongoing data infrastructure need to change? Because it's information that we need for the long term, not just for the immediate.
Great. I have to tell you, there are a number of people that love your concluding motto, and many of whom are going to borrow it and ask themselves every morning how they can add value. So right there, you've accomplished a great deal. So one question along with that, the comment about your motto is, how feasible are broad multi-level collaborations in transforming timely access to health and care?
Yeah. It's trite to say they're as feasible as we want them to be. We've seen some examples of where that has happened, right? Some examples of collaboration, for example, across jurisdictions. You look in the very early phases of the pandemic, one province stood up a tool to allow people to self-assess on their website and made it available to many others straight away so that they could white label it and stand it up too. So, there are examples that we've seen that happen really fast. There are also instances where that hasn't happened. And so where we've seen failures in care because the networks, the resources that were needed were probably available in the community somewhere, but the networks and the capacity wasn't there to get the people who were needed to where they were needed, or the stuff that was needed to where it was needed, or the systems in place, or whatever those gaps in any of the 5 S's were. And I think as we look forward, that's part of our challenge, is to say, how do we navigate those areas where we now have a very visceral understanding of the gaps. And also, and this is part, I think, of the Voices from the Future. You know, I'm so interested in talking with folks. I've had the opportunity in China, in Italy, and some other countries that are further ahead of us on the curve, because they can give us some insights about things we may not be aware of yet, because they're seeing it already. And so can we use their insights to help to see it first and earlier in the process?
That's great. We have lots of questions here. I think what I'm going to do, there are several around patients and caregivers, so we've obviously got lots on the line interested in your perspective. So I think rather than trying to go through all the questions, what I'll do is I'll invite you to speak a little bit about the choice, you know, the decision to have a patient leader, an emerging patient leader. So what was your thinking behind that? What do you think will be achieved with it? And just give us a little bit of your insight around that, and what your hope is for that bursary.
I mean, it's a wonderful luxury, Maggie, to have the opportunity to identify a recipient of a bursary. And traditionally, it's been an emerging leader in a healthcare organization, I think, or in a research organization, and so important to support people in that context. There's another community, though, who there's not that many formal supports for learning and engagement, and that's the patient partner community. And so, you know, when I was given the gift of the opportunity to say, how might we use this bursary to really advance opportunities, that's what came immediately to mind. And, you know, how can we support folks who maybe, you know, still fairly early, we're still targeting an emerging patient partner leader, so early in their patient partner journey, but who a bursary and this kind of support could give a huge boost to in terms of their contributions that they could make. And back to your earlier comments and questions, you know, that voice and that perspective is so important right now. So how could we take advantage of this opportunity to lift up that voice?
That's great. Thank you very much. I think I promised Jennifer that we would end on time or a little bit early so that people have time to go to their next meeting or their next session. And besides that, my dog is snoring in the background, and none of you want to see that. So what I would like to do is thank you very, very much, Jennifer. And I'd also like to thank you, Diane, for being with us today as well. And I'd like to thank our sponsor, the Canadian Patient Safety Institute. I think we've all recognized through this pandemic the vital importance of data and informatics, how we use it, how it informs our decisions, what it means when we don't have enough data or the right data. So having this conversation today has just been so enlightening and so important. So thank you. I want to thank everyone on the Zoom line. I was going to say phone, but on Zoom, for being part of our discussion today and for being part of Virtually Casper. As you know, this is our first foray into holding a virtual conference, and it's a great learning opportunity. I'm hoping to sleep after tomorrow night because I think we've all been, you know, worried somewhat about how it's going to go. But thank you so much for everyone, to everyone for your attendance, your engagement, your questions. I want you to know that we haven't been able to answer all questions, but we will be following up. So you can expect an email, hopefully with an answer, but if not, at least with some direction about where you can go about the answer for your question. And I did also want to just let you know that we will be sending out evaluation forms at the end of Virtually Casper. And we really, really, truly invite your feedback. We need your feedback. Our intention is that we want to grow this program into a robust program for our members. So also we encourage you, if you aren't a member, to sign up. If you are a member and need to renew, please go and do that because we think we've got exciting things in store for you. And in the meantime, you know, it's closing in on 3 o'clock Eastern Daylight Time. I want to wish you a good evening. I look forward to reconnecting with all of you tomorrow for day 2 of the conference. And be well. Thank you very much, everyone.